Good afternoon, everyone. This is Yvette Kelly with the Community and Managed Care Technical Assistance Center, and I'd like to welcome you to today's webinar, Substance Use Disorders, Tailoring Treatment. Before we get started, I want to take a moment to orient everyone to the WebEx system so you know how to participate in today's event. Please note that upon joining the webinar, you've been placed on mute to avoid any background noises that may distract others from listening to the presentation today. If you come across any technical issues during today's event, please chat to the host, who will be able to assist you. You will also have the opportunity to submit questions for the Q&A portion of today's presentation by utilizing the chat box feature, which is located on the right-hand side of your screen. If it's not visible, click the dialog bubble on the top right toolbar and it should appear. Please remember when chatting in questions to send to all panelists so we all can view. In order to ensure that we're able to answer as many questions as time permits, we are requesting that you send in your questions at any point during the presentation. In the U.S., we know that millions of people at some point in their lifetime struggle with problematic drug use. Research has shown that oftentimes substance use disorders co-occur with a range of mental health disorders, further adding to the complexity of identifying, assessing, and treating individuals. This webinar will assist providers in understanding and identifying treatments that exist within the continuum of care. Today, we will be joined by Marcus Doherty and Tiffany John. Mr. Doherty is the Assistant Program Director of Healthcare Reform Consultation at the National Center on Addiction and Substance Abuse. Mr. Doherty has over 25 years of experience in the fields of addiction and mental health and has overseen the delivery of substance use and mental health services in residential, outpatient, and homeless settings. Ms. John is a research associate at the National Center on Addiction and Substance Abuse, working in the Adolescent and Family Research Division. She is a licensed master social worker and has experience delivering behavioral health services to youth in residential and criminal justice settings. Marcus and Tiffany, thank you for being with us today. And at this time, we're going to pass it over to our presenters to get us started.
Thank you, and thank you for that presentation. I'd like to start off by welcoming you all to today's webinar, which is Substance Use Disorder, and we'll be talking about tailoring treatment. Before we get started, just a little bit about who we are. We're from CASA, which is the National Center on Substance Abuse. We're a nonprofit research and policy organization, and we really focus on understanding, prevention, and the treatment of substance use and addiction. And our goal is really to connect science with policy and practice to better the lives of all people impacted by substance use and addiction. Okay, within CASA, Tiffany and I are part of the MCTAC team, which is also part of the Community Technical Assistance Center of New York. And MCTAC here at CASA is basically a training, consultation, and educational resource center. And we offer resources to all mental health and substance use disorder providers in New York State. And MCTAC's goal specifically is to provide training and intensive support on quality improvement strategies, business, organizational, and clinical practices, and to achieve the overall goal of preparing and assisting providers with the transition to Medicaid managed care. So that's just who we are in terms of CASA and in terms of the MCTAC team here at CASA. Okay, now I would like to change slides and kind of go into treatment addiction. And I would like to kind of start off first with just kind of talking a little bit about addiction treatment. And the first thing I'd like to mention is that addiction treatment is a treatable disease, okay? And the treatment interventions that we use today are specifically physician-driven, team-based, and use an array of evidence-based pharmacological and psychosocial approaches. And this is really important to keep in mind because of the fact that addiction is a treatable disease, but we really use a multifaceted approach to its treatment. Some of the things we'll talk about today briefly are MAT, or medication-assisted treatment, different psychosocial approaches, and a combination of those types of treatments. And we'll also talk about the different types and models of treatment today also. So the key thing to keep in mind is that addiction treatment is really available in terms of a continuum of care. Okay. One of the first things that we think about in terms of addiction treatment is how do we identify what type of treatment a person or an individual may need. So one of the ways that that happens in New York State is through the Locator, which is a level of care, a referral instrument that's used by OASIS and is also used by providers also. And it's really an instrument that determines the level of care that a person that has addiction may need. So it may indicate outpatient, inpatient, residential, or other levels of care. So this is important because it really identifies the level of care that a person with addiction may need. And just to clarify, it's a tool that's used in the initial part of assessing where a person needs to be in terms of their treatment. Okay. So SUD treatment providers, managed care plans, and other referral sources use this web-based tool to determine the most appropriate level of care. Okay. So moving on to the next slide. Okay, so when we talk about SUD treatment, it's important to know that there are several modalities of treatment. And on this slide, this really just briefly speaks to the types of treatments. So we have inpatient, crisis services / detoxification, residential, and outpatient. And in the slides that you'll see shortly, we're going to talk briefly about each modality. And then in addition to the treatment modalities, there are additional services, which are recovery support services and peer supports as well. So if we look at the next slide here, it speaks to what inpatient treatment and what inpatient services are. So you see we have inpatient, and then within inpatient, we have inpatient rehab, which really is 24-hour medical coverage and oversight. And this particular service is for individuals that are not in need of medical detoxification. So these services are also short-term and intensive. So that's one modality of SUD treatment. So the next level, or another level of care within the continuum, are what we term crisis services. And this slide, and I won't go into the whole slide, but just kind of defines what crisis services are within the SUD system. So we have medically managed withdrawal services, and those just briefly are like basically hospital-based. Then we have medically supervised withdrawal inpatient. So these are physician-directed 24/7 staffing and 24-hour medical coverage. And then the third level within crisis services is medically supervised withdrawal, particularly outpatient settings. Okay. So once we move from inpatient to crisis, then the next level within the continuum is residential. Now, it's just briefly, it's just important to mention that within OASIS, there's been what we call a residential redesign. So the residential services within OASIS, within the residential system, has gone a overhaul or a change in the structure. So if you look at the structure now, you'll see that there's three particular types of residential services within residential services in OASIS. And the first one is what we call stabilization, which really the goal is to help to stabilize residents that are coming into this particular level of care. The focus is on individual and increasing coping skills, okay? And really with stabilization, you're looking at isolated withdrawal, and you're looking at other types of medication-assisted treatment approaches, okay? Also within residential, we have rehabilitation, okay, which really focuses in on managing emotional states, urges, cravings. And then the third element within residential is reintegration, which is really the goal in this particular element of care, is really to assist residents in reintegrating into their community or into the community. Now, also the important point to mention is that based on the locator, a client may go into any one of these any one of these levels of care based on what the locator indicates. So someone could come into residential at rehabilitation, for example, or they may come into residential at the reintegration stage. So again, it really depends on what the results are of the locator in terms of indicating the appropriate level of care. Okay, so another element of, well, another level of care within a continuum is really outpatient. And if you look on this slide here for outpatient, you'll see 4 particular types of outpatient services. Again, I won't go into great detail, but one particular level is outpatient clinic level, where the length of stay and the intensity will vary depending on the course of treatment. So again, if you look at if I go back to the locator might indicate that an individual needs outpatient services, and it may indicate an outpatient clinic. Okay. Another level of care within outpatient services is what we call intensive outpatient clinic, or IOP services. So these are really time-limited, multi-faceted array of services that usually go from 9 to 12 hours a week of intensive service, okay? And they can include individual, group, family, counseling services, and an array of different approaches. CBT interventions, for example, motivational enhancement, development of coping skills, and other approaches to deal with environmental and emotional stresses. So this is really IOP, which is really intensive outpatient treatment. Okay, and they're usually housed within an outpatient clinic. Okay. Another type of service within outpatient is outpatient rehabilitation, and this is usually, initially, it's from 3 to 5 days a week for at least 4 hours a day. And then our next level of treatment in an outpatient setting would be OTP, or opioid treatment program. Okay. So these are the services that we have in the continuum of care respective to outpatient treatment. Okay, and at this point, I'm going to turn the presentation over to my colleague, Tiffany.
Hi, so we're going to switch over and talk a little bit about evidence-based practices. This is a term everyone's probably heard and is familiar with, and this is because it indicates the highest level of care or evidence for care, and we really encourage that anyone with an addiction is treated using an evidence-based treatment. And the most well-known definition for an evidence-based practice is integrating individual clinical expertise with the best available external clinical evidence from systemic research. What this really means is that there are scientific findings to demonstrate their effectiveness or efficacy in improving client outcomes. But it also combines an individual who's providing the treatment, their expertise, and then really considering the patient values and preferences in determining course of treatment and patient goals. So for substance use specifically, there are several evidence-based practices, and they're divided up into behavioral and then also pharmacological. So first I'm going to talk a little bit about the behavioral evidence-based practices. I'm just going to give a brief overview. So there's motivational interviewing, contingency management, family therapy, and cognitive behavioral therapies. This is not all of them. I don't want to get into too much detail, but different evidence bases have different levels of effectiveness, but these are the ones that have been researched the most and demonstrate the most effectiveness, so that's why I'm going to talk about them today. And so just for motivational interviewing, this is a modality that is used to help people resolve ambivalence about engaging in treatment, really identifying their treatment needs and their own internal motivation for wanting to stop drug use and engage in treatment. And then contingency management involves giving patients tangible rewards to reinforce behaviors. This can be slightly controversial, but research really does show that it is highly effective in increasing treatment retention and promoting abstinence from drug use. And there's two different ways that this works. They could be vouchers that can be exchanged for items. So as clients continuously have submit urines that are free from drugs, that they get a voucher that increases in value that they can exchange for things like movie tickets or other things that they might want. And then there's another one where they can submit every time that they have a clean urine, like their name into a bucket to draw for prizes. And this works with both adolescents and adults. And then cognitive behavior therapy teaches individuals to recognize and stop negative patterns of thinking and behavior. And it really helps someone just connect their thoughts to their behaviors and feelings and really think about substituting new behaviors or identifying different patterns to create new behavioral patterns. And then especially for adolescents, family therapy has been mostly researched and is demonstrated to be very effective across different races, ethnicity, ages of youth. And what it really aims to do is go beyond just substance use and address larger family risk factors, improve family communication, family cohesiveness, and increase problem solving to really go beyond what happens at family therapy and just promote better outcomes for youth in general. And there's different modalities. There's multidimensional family therapy, multisystemic family therapy, brief strategic family therapy, and functional family therapy. And each one has different ways of working, but there is research looking into what are some common elements across all family therapies that could be used to help really improve those outcomes for youth. And then we have what are called manualized evidence-based practices, and these are really helpful for providers who are delivering these services because they have been created into a format that can be implemented across different sites, and they come with like worksheets and activities that can be done with the individuals in treatment. And another thing about evidence-based practices, as Marcus was talking about the Locator with different levels of care, these can be used within different levels. So once someone has determined what level of care they need to be in, then it's more finding which modality and what kind of treatment they might respond to. Okay, so I'm going to talk about medication. So this is an evidence-based practice. Research has shown that these medications are helpful for people. And the definition is it's an effective treatment for opioid addiction. It involves combination of behavioral therapy with FDA-approved medications. And that is why it's called medication-assisted, because even though we are giving the medication, it really should be supplemented by one of the behavioral therapies that were talked about on the previous slide. And the benefit of these medications is it helps normalize brain chemistry, and it can block the euphoric effects of both alcohol and opioids. So when we talk about medication-assisted treatment right now, there's only medications for alcohol and opioids. There is research for other substances as well, but the evidence is not quite there yet. And then also it can help relieve the physiological cravings, so that way the person can engage better in treatment and focus on other things that they might want to be improving in their lives as well. So currently there are 3 different FDA-approved medications, and they are methadone, buprenorphine, and an injectable naltrexone. The common name of that is Vivitrol. Now, as you can see from this slide, they are treated a little bit differently. They work differently on the brain, either by blocking the opioid receptor or minimizing the effect of the drugs. So for methadone, they can only actually currently be prescribed in what is known as an OTP, and it's highly regulated, whereas buprenorphine, there are special waivers that physicians can obtain so that they can provide them in an office-based setting, and people can actually take this home and take it home, whereas methadone is usually you have to go and get your dose daily. And then Vivitrol is long-acting, and it's usually a monthly injection. Okay, so I'm going to switch, and we're now going to talk about recovery. So as we talked in our previous webinar, that addiction is a chronic disease, and it is important to provide long-term management instead of viewing it as like a short-term. We can do small things here and there, but really to look at it similar to diabetes or hypertension, where we kind of go in and out of, an individual might go between abstinence and active use, but that's still considered as part of their path to recovery and a normal part of the process. And it is also important to notice or to be mindful that everyone is capable of sustaining recovery, but everyone's path might be a little bit different. And everyone has different goals, and they can reach their goals through different ways, but like a one-size-fits-all approach isn't going to work for everybody, so it's really important to tailor the recovery process for the individual as well. So recovery can include different treatments, medications, and other supports, and these supports can address the personal, psychological, and environmental risk factors that could cause an individual to seek substances and really help put some supports into place. Oops, skipped. Sorry about that. Okay. So these services can be provided before treatment, during treatment, or after treatment, but it's always important to start thinking about recovery even at the beginning of the treatment process and not wait until someone is leaving treatment to try and start identifying those supports. We really want to get those in place to really help that person sustain recovery. So they can be provided in schools, healthcare systems, there's recovery housing, and community settings. There's even recovery high schools and sober campuses where kids can go to make sure that they're surrounded by peers who are also in recovery and have that peer experience. There are also what are called auxiliary services, and these address those other issues that could lead to more stress, that could cause someone to seek substances again. So this is stuff like housing, employment, any kind of legal issues, even transportation. So those are an important part of recovery services that help with outcomes. So another type of recovery service is what is called a mutual support group. And these are probably the most common that people, when they hear about a recovery service, will recognize, such as AA is one of the most common ones. But these allow for individuals to seek and provide support within a group of their peers. They are not themselves treatment, so I just want to caution, sometimes people think these in themselves are treatment, and they're actually not, but they're really good to be incorporated with treatment and often are incorporated into the formal treatment programs, and attendance is very helpful for many people. But what they are is they're non-professional groups, usually run by internal members, not like a counselor, but just within itself. And they usually have steps that go along with it. And I'm sure most people have heard of like the 12-step program that is associated with AA. There are also groups for members of family or friends who want to have a support group as well. So those are Al-Anon, Alateen, and also different substances have their own support groups, and there's different modalities. Even if someone wants to find like an agnostic one within AA, there's just different groups, different age groups, et cetera. So there's really different options that are available for anyone seeking one. So finally, we're going to talk about peer supports. And peer supports are also really gaining momentum, and New York State is really recognizing the importance of peers and expanding peer services. So peer supports are those that are provided by individuals who are themselves in recovery, and they can help by sharing their own experience or serving as a resource, connecting to other services and supports, or helping someone get into treatment. So these can include recovery coaches, which is a partnership where the person who is in recovery gets to self-direct what they want their recovery to be, but then get expertise and coaching from someone who's gone through the process before. And then also OASIS has come up with special certifications, and one of them is a certified peer advocate. And this is a person who provides outreach, advocacy, mentoring, and recovery support services to those seeking or sustaining recovery. And then within that, there are even newer ones for youth and family. So someone who is 18, in the 18 to 30-year-old range, can have someone who is closer to themselves in age who helps them with this process. And peers can really help if someone is they're not sure where to start, how to get connected, or need questions answered. So they can really help serve as a bridge between an individual seeking treatment and the treatment system. And then it's also, I wanted to mention that peers are considered a very important part of the addiction workforce, and that most organizations are finding ways to incorporate peers into their own workforce. And the final designation that OASIS has is that for a family. So this is so if a family has someone like a youth and they need extra support, the CERPA family coach doesn't necessarily have to have gone through addiction themselves, but also have had a family member, and they can really help the family through the process. So at this point, we can open it up to Q&A.
All right. Thank you, Marcus and Tiffany. And so it was very helpful for you to go through the different levels of care and talk about that. And we do have some questions that have come in related to approaches and what's being used out there. And so one of the questions that was asked is, there's an individual who has a client who now is in need of some either long-term rehab or residential services for whom 12-step programs are not a good fit. So how can one identify potential placement facilities that don't use that model or approach? And as I heard you mention in the presentation, it seemed like it is widely used, but what happens to the individual who that's not a good fit for?
Good question. Thank you for that question. I would say, just to go back briefly, and I'm going to answer the question with just a little bit of a brief history. Once again, the locator is really the instrument that's used to indicate the appropriate level of care. One of the suggestions that I would also make, too, is that once the appropriate level of care is identified, you can always, for lack of a better term, kind of shop around and find out what type of provider would be most appropriate. And you can ask questions like what type of services are offered. You can ask about the admission criteria. You can ask about the programming. So really, I think the key is that once the appropriate level of treatment is identified, you want to make sure that the provider that provides that level of care is also a good match too. So it's always good to ask about the program, ask about the mission, the philosophy, ask about what the treatment entails, and make sure that's a good match.
Okay. So, Marcus, you kind of answered one of the other questions that kind of went along with that, which was how do you identify kind of what the specific evidence base or the program that residential providers are utilizing in treatment? So that was helpful. There's also a question around, and there was individuals who were not really clear about the difference between, a couple individuals not clear about the difference between the first two inpatient treatment modalities. So can you just spend a few minutes reviewing that for our audience, please?
Sure, and if I can, I'm going to try to go back to that particular slide.
Yeah, and go to slide 9, if I'm correct.
Okay, treatment modalities. Okay, thank you. Sure. So let me start from crisis services / detox. So these are really services that are used for individuals that really need detoxification, but at different levels. So based on the type of detoxification that someone is experiencing, they may need hospital-based care in terms of detoxification, okay? There are other levels of detoxification that may not require hospital-based care. So I'm going to move to the crisis services slide here. So, for example, the medically managed withdrawal is hospital-based care. And again, those are for folks that are experiencing severe withdrawal symptoms or they're at risk of severe withdrawal symptoms. So they will require acute physical or psychiatric comorbidity or care. So those are really folks that have severe withdrawal symptoms that will need a hospital-based setting in terms of their withdrawal services. Then we have medically supervised. This is really like a step down from the medically monitored withdrawal, where these individuals would need to be in a setting that is physician-directed. There's 24-hour, 7-day staffing, and 24-hour medical coverage. So these are for folks that have moderate withdrawal symptoms, and they're not acute in terms of their physical or psychiatric symptoms. And then we have the medically supervised withdrawal, which is really outpatient. So folks that have moderate alcohol or substance withdrawal, but they don't meet the admission criteria for, say, medically managed or medically supervised crisis services. So these are your basic outpatient programs that can provide medically supervised withdrawal treatment.
Right.
Okay, I hope that answers the question.
Yes, thank you. And if that still is unclear or someone needs some more clarity, please feel free to chat in and let us know. We'll make sure to ask. I have another question related to folks who are serving individuals with SUD problems in mental health clinics. So what can folks do at the outpatient level to increase the level of care for people who are suffering from SUD who do not want to yet seek out OASIS services?
A good question. I would say that within our SUD system, there is a need for some services for the mental health end. So I would say that that should be a part of overall treatment. I think one of the ways that we have to look at treatment today is looking at it from a holistic approach. So we're treating an individual that has an SUD, but in order to be effective in an overall treatment, we have to look at one's overall health. So I would definitely encourage individual treatment providers to look at SUD treatment, although it may be the primary reason why the person is in one of our levels of care, but we're also looking at the individual's holistic treatment. So we wouldn't want to deny other levels of treatment that are also important to that person's overall recovery. So individuals should be encouraged and should be part of treatment planning to encourage treatment for other areas in their life as well. So SUD treatment would be paramount in terms of what we provide, but we're always looking at the person's overall treatment.
Thank you. Another question is around getting clients access to services. And so it says, can you talk about where a client might go when they're in the midst of a withdrawal? So apparently this individual's had some clients who tried to detox by themselves, and by day 3, they just couldn't handle it anymore, and so they were attempting to go to the hospital to seek out treatment, but they weren't necessarily admitted because they no longer had the drug in their system. So what would you recommend for individuals who are kind of in that situation where they're really trying to do it on their own, but they've come to a point where they've recognized they need some additional assistance?
Good question. It sounds like the individual, from what you mentioned, went to the hospital, but the hospital didn't admit or didn't feel that they needed that level of care. I would say that, number one, if you can get to an SUD professional in an outpatient setting, it can be an outpatient clinic, it could be in a WASIS-funded clinic or setting where an assessment can be made. And I will also suggest, too, that if the person went to the hospital and the hospital didn't feel they needed that level of service, the hospital should also be able to provide a list of referrals for the next level of treatment. So just to sum that up, I would say hospitals should provide resources for the next level of treatment if they don't require medically managed withdrawal treatment. And also there's information on the OASIS website, and there's also outpatient clinics in the community that individuals can go to.
Okay, thank you. And so we have someone who doesn't really have much experience in the substance use and would like for someone just to explain a little bit more about what the Locator is.
Yeah. So the Locator is a tool that was developed between CASA and OASIS, and the goal of it really was to make it so that anyone who is administering the tool in any setting, so like if I went to a hospital or if I went to an outpatient clinic, no matter where I went, the Locator would still, the assessment would be the same, and that I would still get the same level of care determination. So really wanting to have a tool that everyone could use and get the same results. So what it is it's a person would go through any kind of assessment that would normally be done, and then based on that assessment, the Locator is a web-based tool, so the person who performed the assessment on the individual would answer a series of questions, and the questions really look at what are the supports this person has, what are their symptoms, what substances might they be using, do they have any physical health problems, are there any other mental health concerns that they might have, what other risks and resources they have, and based on those questions would give a recommendation for what level of care that person should go into.
Great. Thank you for that explanation.
Welcome.
There was a question around, Tiffany, you reviewed some of the medical-assisted treatments.
Mm-hmm.
When you're talking about that, are there any specifics in terms of who's eligible for those for that type of treatment, including age?
Yes.
Like, okay.
Yeah. So
that a little bit.
Yeah. So I don't know. I mean, like off the top of my head, I do know certain ones are indicated for certain individuals based on their past medication history or where they are, and I don't want to tell you the wrong answers, but it is true that like some patients do better with methadone where some do better with buprenorphine. I can say that the injectable Vivitrol is really good for people who are not good at taking a daily dose because you only have to do it once a month. And some of them are safer compared to like their risk of being diverted or overdosing, like, and I can't remember which one that is either, so again, I don't want to tell you the right one, but a medical professional can do an assessment and usually will recommend what they think out of the 3 is best for an individual based on their history.
And if I could just add to that, I think the important element to keep in mind about medication-assisted treatment is that it is not just the medication alone. It's always a combination, or should always be a combination of the medication and psychosocial supports in combination. So For example, it would be medication, and it would be counseling or therapy or other supports for the individual as well. So it's really a combination of medication and psychosocial supports as well.
Thank you. Thanks for that clarity. And just one other follow-up question to that. Is that a particular type of treatment that, for instance, may be utilized in the adolescent population? Is there an age criteria for utilizing medication-assisted treatment?
That is a really good question, because a lot of the research that has been done has mostly been done in adults. So there is research with adolescents, and what the consensus is that it is safe for adolescents. The most research has been done with buprenorphine, so that is what most adolescents are really, doctors are saying is the safest, but it really should be an individual case by case, and because of age, they shouldn't be automatically not considered for a certain type of treatment. So it really, again, should be based on that tailoring for what's going to work for that client. But age shouldn't be a barrier, because in the past it has been, oh, like, this person's not 18, we shouldn't, and we're moving away from that.
Thank you. Some other questions. So how are patients with substance abuse managed differently, if at all, for pain post-surgery? So like individuals who have significant histories when they're in the hospital, what's the recommendation in terms of treating that individual for some, chronic post-surgery pain?
Good question. We don't really have the answer to that question, but what my suggestion is that it would really need to be a decision made by that person's primary care provider and their substance use professional. Pain management is really the purview of, again, of the medical professional in combination with the client and the other treatment providers. So we couldn't give you a specific answer other than just that it has to be a medical-based decision along with other behavioral health providers.
Thank you. And we do have a few other questions coming in, so I just take a moment to just
Sure.
look through them and just make sure they're scrolling very fast, so I apologize. So if a client is referred to outpatient services and fail to show up, is there anyone that comes out to the person's home or shelter where they're residing to do any follow-up?
Very good question. And actually, in Oasis outpatient programs, there is now a new service called community services, where the program, the outpatient program, can actually send staff in the community to do that type of follow-up and do the type of services in the community. So say, for example, if a client hasn't shown up for a couple of days, a staff could be sent to that person's home and could provide actual treatment and services there. So that is a service that outpatient programs do have the capacity to provide, and it's really a great service because it helps to keep clients connected, and it's also can be used for engagement as well as treatment.
Thank you. And I think this is going to be one of our last questions. We're going to end a little early here, but in terms of residential services, what types of other auxiliary services do they offer to folks who are in residential settings like long-term? Do they do work around job attainment, employment, and things like that? Can you speak to a little bit about what might be offered in those settings?
Yes. Within residential settings, those services are offered. So, for example, let's take the rehabilitation element. So those services are definitely provided there. So it could be assistance around vocational services. It could be treatment around, skill development. It could be treatment around developing coping strategies, case management services, and then also continued stabilization and rehabilitation services. So those are all provided within the rehabilitation component. And then the reintegration component is really about reintegrating and preparing an individual to live within the community. So that's the reintegration phase, where a lot of the services that are provided in the rehabilitation and reintegration, they're provided in the community. So the services that I just talked about that one may receive in rehabilitation has now been moved to in the community when a person moves into the reintegration stage. So those are just examples of some of the services that are provided. And again, the whole goal in residential is to really move a person from residential to reintegration and then eventually back into the community using an array of services at each level. If I could just add to that for a second, folks that are coming in at the stabilization element can still receive those types of services and still move through the elements of care. So if someone comes into stabilization, for example, and they started on MAT, they can continue that through the other elements of care if they move through those elements also.
Okay. And there are a few other questions that have trickled in, so I'm just going to, since we have some time, I am going to spend some time addressing them. So the question is there a mobile crisis unit available 24 hours where if there's a client in crisis, they could call someone, providers could call someone and have someone come on site?
To be honest, I'm not aware of a mobile crisis unit per se, so I would say that I'm not aware of such a service.
Okay, and what would be your recommendation just in terms of, again, if a provider were to run into someone who is in an immediate crisis or immediate need, what would you recommend that be their first step?
I think, again, it will really depend on the level of crisis. I mean, obviously, if someone is in crisis and you're not sure, I would say sending them to the hospital would be the immediate thing. Now, that depends, again, on the level of crisis. If someone is in an imminent risk or a crisis that you perceive as being life or death, yes, send them to the hospital. Sometimes overdose can look very menacing, very threatening, so yes, send them to the hospital. And then from there, the hospital can make a determination in terms of the type of treatment that's needed. But someone that's at different levels of crisis, you may need to do different things. So if someone, for example, is in withdrawal, okay, you might still need to send them to the hospital, but if you know that they're in treatment or they go to an outpatient, maybe reconnecting with that outpatient program, reconnecting the client with it. So again, it really depends on what the person is presenting with in terms of a crisis or in terms of services.
Thank you, Marcus. All right, and this will be our final question. And there are other questions, let me just say that there are other questions that we're not going to be able to attend to on this webinar, but we will reach out to those individuals separately and make sure we get them a response. But one of the last questions is, what level of monitoring do they do for weekend methadone dosages from, and maybe you might know these acronyms, whether OTP is outpatient treatment, or MMTP. Is there some enforcement? I'm not sure if you know what that acronym is. I don't know that. MMTP?
Good question. I would say that really depends on the progress of the individual client and the OTP. The amount of dosing and the amount of medication given out on the weekends, if it is, again, really depends on the treatment progress of the individual. And that's usually a team decision within the OTP. And again, it's based on the progress, the treatment progress of the individual.
All right, so Marcus, what I hear you saying is that it is monitored via treatment planning, via the treatment team. And so if there's changes or some concerns around, the dosing, that would be done through that process.
Yes. Definitely.
Perfect. Thank you. All right. Well, thank you, Marcus and Tiffany. I just want to thank you for taking the time to kind of walk through some of these treatment modalities. It's very helpful. Again, as I mentioned earlier in the presentation, there are lots of providers who are learning to really begin to bridge some of the gap between the substance use world and the behavioral health world. So I want to thank you for joining us, and I want to thank everyone for attending today's webinar. Again, as I mentioned, there's some questions that we'll make sure to reach out to those people individually to address. But if you have any other questions, please feel free to contact us at ctac.info@nyu.edu, and we'll make sure to address your concerns. So thank you, and enjoy the rest of your day.
Okay, thank you.